My name's Darsh. I'm a PA student here at the University of Manitoba, and today I'll be giving a talk about something that is what I found on my clinical rotations was an important topic to bridge the gap between medicine and dentistry. So my topic for my capstone thesis project for my degree was identifying barriers from implementing an early childhood caries risk assessment tool for non-dental primary care providers. So I did this with my mentor and advisor, Dr. Robert Schroth. I was hoping to see the connections and build on themes that we could potentially use to implement in primary care and caries risk assessment tool. So today what I'm going to talk about is just what I went through in terms of why I chose this topic, how I conducted it, what the results showed, what the literature actually shows about what my results kind of illustrated and what overlap there is, and future direction for people to build on this project and coincide and try to gather more information in a bigger study. And in the end, if anyone has any questions, feel free to add them in the chat box and we'll talk about it at the end of the presentation. So today's objectives, what I'm trying to illustrate is, first of all, trying to just understand the importance of what early childhood caries is and how it affects Canadian children. It's something that is prevalent in the community. It's hard for parents to actually get the preventative treatment, and it's something that has been relatively unchanged over the last couple of decades. So I feel that it's important to touch on about that. Also to look at the role of non-dental primary care providers. We know that there are a lot of physicians, PAs, nurse practitioners, dietitians, social workers that see children in primary care settings. So to utilize their resources and roles and trying to combine that with having a risk assessment tool was one of the aims of this project. And also I will discuss themes identified through my research in focus groups about what barriers actually exist from the participants that I had in my study to show that we can figure out these barriers and have an implementation project to use this caries risk assessment tool in practice. So just a brief introduction into the topic. So early childhood caries is something that it's affected by many factors. It's affected by things that we eat, the microbe, the bacteria that are in our mouth, as well as the tooth integrity. So it's not just one factor that goes into how these carious lesions develop over time. And as I mentioned before, it's something that hasn't changed in the past 3 decades, and it's been more so prevalent in urban and rural communities due to the underlying social determinants of health. One example is low socioeconomic status. We see that as cost of living increases and we haven't seen wages increase as well, parents are faced with the difficult decision of putting food on the table or making healthier choices. So that has actually led to more incidents and hasn't really had an impact over the last couple of decades. And one of the most important facts here is that once caries are untreated and progresses through the various stages, it can end up requiring invasive treatment, such as dental surgery. And it's actually one of the most common day surgeries in young children at most Canadian pediatric hospitals. It's also important to note that there's a long wait list for these procedures. So although children may require it due to progressive carious lesions, they may be affected by a long wait list and have complications from this, such as infections or possibly even the loss of the permanent teeth or damage to the permanent teeth if their primary teeth are affected. So from the Canadian perspective, we see that in the Indigenous population, especially in Manitoba, that they're significantly affected, meaning that they have a considerably higher incidence of carious lesions compared to the national average. And as Canada welcomes new immigrants and refugees, we're seeing more challenges in accessing and maintaining their oral health. They may not have the resources or have the direction to pursue dental care in this country, whether that be due to a language barrier or a cultural barrier. And we see that there's more incidence of higher risk of carious lesions in these populations. And a key point to also note is that urban children in centers throughout Canada are just facing the same similar situations that children are facing in other disadvantaged communities. So although Indigenous populations are significantly affected, we are also seeing a disproportionate amount of urban children being affected in communities in urban centers in Canada. So one of the primary issues that I was able to identify was that less than 2% of infants visit dentists in their first year of life, compared to greater than 82% visiting medical professionals such as physicians or nurse practitioners or physician assistants. That's a huge gap in the system that we see. People are more inclined to see their doctor than they are to go to the dentist. So that is one of the key factors that may be leading to the progression of these carious lesions over time. A study that I was actually able to find was that physicians who actually utilize any oral health services in their practice have been able to reduce treatment cost of caries associated hospital visits by 32% in children up to 3 years of age. That's a significant portion of the healthcare system that can be resource allocated for these children if we can actually utilize oral health services in primary care settings. A survey in actually the United States did show that pediatricians believe that greater than 90% of them actually stated that dental assessments and preventative counseling can be incorporated into well child care visits that we actually already conduct. So when we have children coming in for their 1 month visit, for their 2, 4, or 6 month well child immunizations, we can actually incorporate these early childhood caries risk assessments for these children if we take the time and have the ability to incorporate a caries risk assessment tool. So overall, my goal of this whole project was to figure out how we can have increased identification and earlier intervention for early childhood caries as these children go to their physicians and primary care providers more so than they do to their dentists. So basically, we have this caries risk assessment, and we have this problem of early childhood caries progressing and affecting children at such a high rate. So looking at a caries risk assessment, basically what this is that it's a tool to assist with clinical decision-making and disease management. It's basically a tool that primary care providers can use to address carious lesions, intervene, and be proactive rather than reactive. We're trying to prevent irreversible damage to teeth, and having a caries risk assessment tool can actually help intervene at an earlier stage so that they don't need to go through to the end of invasive dental surgery under general anesthesia. So at the end of the day, we're trying to reduce pain, failure to thrive in these children, and overall diminishment of their quality of life. Having children go through multiple dental surgeries is quite of a mental roadblock for them, and it can leave scars for the rest of their life. So if we can intervene and prevent the progression of these carious lesions at an earlier stage, it can improve their long-term outlook. On this slide, I also have the Canadian Caries Risk Assessment Tool made for children under the age of 6 years of age. It was made by my mentor, Dr. Robert Schrott. It's easy to fill out. It's got factors and questions at the top. It gets you a score that you can rate as a high risk or a low risk. And overall, what the point is to figure out if we can re-educate parents and re-educate the children about how to maintain good oral health, as well as looking at the potential for applying fluoride varnish in the setting that they're in the primary care office. We also, you can see for all children to refer to the dental office. We see that there's a disconnect potentially between medical providers and dental providers. So having that referral process in place so that they can be encouraged to get those services is something that this Canadian Caries Risk Assessment Tool tries to accommodate and implement. So for my project, what I tried to do was I had two main questions. What barriers exist to prevent an implementation of a caries risk assessment tool for non-dental primary care providers? And ultimately, how can these non-dental primary care providers be trained to utilize this tool in their daily clinical practice? Some primary care providers deal a lot with the pediatric population and some don't. So what I tried to do was I tried to get participants with a wide variety of experience with not only the Indigenous population, but also pediatric and Indigenous population as well. So I tried to look at the training and I tried to see what barriers in their opinion existed for the implementation of this tool. So what my project actually entailed and how I went about conducting this project was I chose to do it as a qualitative approach, mainly using focus group and interview sessions with non-dental primary care providers. Now, I've mentioned non-dental primary care providers a lot in this presentation. So what I defined it as in my project was nurses, nurse practitioners, physician assistants, physicians, and dietitians. In the beginning of this project, I tried to recruit up to a potential 21 participants. In the end, I got only a response to participate from about 9 participants, and 1 was unable to be scheduled. So my project ended up being 8 participants, which was broken down into 3 nurse practitioners, 3 physician assistants, and 2 physicians. I was able to conduct 3 focus groups and 1 interview session, mainly over Zoom, given the COVID-19 pandemic, but I also had the opportunity to do 1 in person, adhering to all COVID-19 rules and protocols. Each focus group session took about 45 minutes to an hour. It was audio recorded with consent from all participants and deleted once I was able to transcribe the focus group sessions data. And in the end, each participant who completed the focus group received $25 honorarium in the form of a gift card for participating. So I have the figure on the right outlining how I went about my project recruitment. One thing just to elaborate is that I was able to get 21 participants, potential participants actually, from by word of mouth, through my mentor, Dr. Robert Schroth, through PAs that I was rotating with on clinical rotations. So I had a wide scope that I tried to get, but in the end, due to whether it be the COVID-19 pandemic, whether it be to scheduling, I was only able to, at the end of the day, get 8 participants out of the 21. So my project did receive ethics approval from the University of Manitoba's Health Research Ethics Board. I was able to collect demographic information from all participants who participated in this project via a survey through SurveyMonkey. What I was looking for there was basically their age, their role in the primary care provider office, and their experience and exposure to Indigenous population and the pediatric population. And all participants, before they were consenting to participate in this project, were sent the Caries risk assessment tool, which I showed a few slides before, and they were given an invitation script outlining all of the important facts about why we're conducting this research project. So here I have the demographic survey that was on SurveyMonkey. It just basically had about 8 questions, with the 9th question just typing to accept and giving their consent to participate, just trying to, and also looking at how much of their pediatric population they dealt with, as well as the Indigenous children and Indigenous population. So when coming up with the interview questions, I sat down with Dr. Robert Schroth and the Healthy Child, Healthy Smile team. And what we did was we tried to come up with questions that we can facilitate honest and open discussion. And what we wanted all participants to do was share their opinion as to looking at the Caries risk assessment tool and sharing their thoughts about what would actually prevent them from using this in their daily clinical practice. So we came up with 11 questions. Some of them were very open-ended, such as just the first question, what are your thoughts on early childhood tooth decay? Some were very focused on asking, what do you see as the benefits of integrating the Caries risk assessment tool into your practice? And the last few questions looked at the fluoride varnish. If they had to have to actually apply the fluoride varnish, what challenges or barriers do they actually foresee in applying this fluoride varnish, and how would they actually get this fluoride varnish? So in the end, it was just trying to get a discussion going between the participants in the focus groups project, participants, and also trying to get them to elaborate and give their honest opinion about it. So in terms of my results, so I had 8 participants who were all from Manitoba, but the majority practicing in Winnipeg. So as you can see, the demographic information laid out here, I had PAs, physicians, and nurse practitioners. Unfortunately, I wasn't able to get any primary care nurses due to their redeployment throughout the COVID-19 pandemic. But what I saw was that there was a wide range of exposure to the Indigenous population as well to the pediatric population. For example, I had one participant who had very minimal exposure to pediatric populations, but had a large exposure to Indigenous populations. And another participant had a lot of exposure to both the pediatric and the Indigenous population. So depending on their scope of practice and where they were actually participating, I had a lot of wide variety of experiences amongst the participants, which was one of the aims, so that I can actually get a wide variety of opinions and discussion from all the participants. And I was, at the end, I was able to identify 4 themes after transcription of all these focus group and interview sessions. So, which is outlined here. So what I found was that 4 themes were identified, meaning I had barrier to implementation being time, provider education, access to resources, and parental buy-in. So these were all overall big ticket themes, and I subdivided each theme into descriptors. So when participants mentioned time, some participants mentioned appointment slots or the value of that use of the Caries risk assessment tool in terms of their time. Provider education, meaning the training being a barrier, or maybe even their comfortability and information to educate others about what the Caries risk assessment tool being a barrier for them to implement this tool. Access to resources, meaning funding. How can they actually get these tools that they need, such as fluoride varnish? And if they could even get these tools, how would they store them? Where would it be? Parental buy-in, mainly focusing on education of the parents and the value of the parents seeing that their primary care providers are providing this service, potentially being a barrier to implementation. So breaking down my results, I had some numbers to show and to share from my focus group sessions. So when talking about time, I expanded to appointment slots, and a significant portion, about 7 out of 8 participants, noted time being a barrier. Obviously, in primary care settings, we're focused with the appointment slots that we have, whether that be 15 minutes or whether that be 30 minutes, depending on whether it's a fee for service or whether it's a salaried primary care provider. Their appointment slots may vary, but obviously time is a big barrier to implement this. It's something that, children come in for a chief complaint, and can they actually incorporate a Caries risk assessment tool into the limited time they already have with these children? So that was one of the overarching results that I found from my project. Another being the value. So how can we prioritize and see the value of conducting these dental assessments? So it does loop back to the appointment slots, but if a child does come in with chest pain or some wheezing, are we actually going to then look in their mouth to do a Caries risk assessment tool, or are we going to actually prioritize the presenting complaint that they came in with? So that was one of the identifying barriers that came up in my focus group sessions. Now, when looking at provider education, training was cited as one big barrier as well. So 3 out of 8 participants noted that continuing professional development can be a source to provide training to non-dental primary care providers. As far as all participants were aware, none of them had specific oral health training other than maybe one lecture on focusing on what teeth are. So developing that training was cited as a barrier, and they used a continuing medical education or continuing professional development to get that training to actually use this Caries risk assessment tool in practice. And then 6 out of 8 participants felt that these pictures did provided in the CRA tool were helpful. So the second page of the Caries risk assessment tool, as seen before, does show what carious lesions can look like. So most felt that they were helpful in identifying caries and referring them to the dentist, but 2 out of 8 did say that they weren't quite sure if they'd be able to identify the very slight small changes seen in the early developmental stages. And then when looking at comfortability, most participants stated that getting into a habit would be a barrier. So conducting this Caries risk assessment tool and having it in front of you is one thing, but what participants did say was that actually getting into the routine and remembering to actually fill this out during the appointments would be a barrier in the initial stages. It's something that you do more often, then you start to pick up and you'd get more comfortable and have a reminder to do it. So in the initial stages, that was cited as a barrier to implementation. And then 7 out of 8 participants noted that an integration with the Rourke record, which is used in well child visits, would increase accessibility. So having a reminder, if it was as the 3rd page in the Rourke record, would actually help participants to actually fill this out rather than it being a separate form. And in terms of information to educate others, most participants noted that the referral process to dentists is a barrier. So as we know, it's very easy for primary care providers to refer to the endocrinologist or to the cardiologist, but it's quite difficult to know who the community dentist is sometimes and how that referral process would be engaged in. So most participants noted that would be some sort of barrier to actually use the Caries risk assessment tool. In terms of access to resources, funding was cited as a big barrier in terms of who would be acquiring this fluoride varnish and where would they get these tools. And to build on that, 2 out of 8 participants noted that where would this fluoride varnish be stored? Would it be in the central location in between all the clinical exam rooms? Would it need to be in the refrigerator? That kind of posed a challenge to them as well. In terms of parental buy-in, so when looking at my interview questions, there was the first question, which I mentioned was supposed to be open-ended. All participants noted that caries can be preventable, and a significant portion mentioned that bottle feeding was a big contributor to caries development. So the education to parents, whether that can be reinforced, was cited as a barrier to actually implementation. Would parents be receptive to this tool? Would they actually want their nurse practitioner, physician assistant, or physician actually doing a caries risk assessment rather than someone specialized such as a dentist? So that was identified as a key barrier in the participants. And finally, 6 out of 8 participants noted that the parents would be a barrier, meaning that should they rather go to the dentist rather than seeing their family physician, that would be kind of hard to explain from their point of view. So after looking at all my data, I wanted to create a graphic to illustrate what kind of ideas were spoken in the focus group sessions. So what I did was I broke it down by profession, so physician assistants, nurse practitioners, and physicians being the MD. So I saw some overlap between what participants were speaking based on their profession, such as if I look at the preoperative appointment slot here in between the nurse practitioners and the physicians, that was cited as something quite common in between the physicians and nurse practitioners. So when children have caries that have progressed to a stage where they need invasive dental surgery, they come in for preoperative appointments. And this was mentioned in the focus group sessions as one of the things that would potentially be a barrier, meaning that since parents come in for these preoperative appointments, would they see the benefit of transitioning over to just doing a caries risk assessment tool in the hope of it not progressing to the stage of needing dental surgery? So that was something common that was mentioned between nurse practitioners and physicians. In terms of looking at holistically all three professions, they all mentioned that this was something that was preventable, and getting into the habit of actually conducting this caries risk assessment tool would actually be a barrier to all 3 professions. And obviously time, how much time do they actually have in their limited time appointment slots to conduct this caries risk assessment tool? In terms of physician assistants and physicians, payment coverage was noted as something that came up in the discussion. Was how can parents or parents of these children afford to go to the dentist? Is there any payment plans that would need to be done? Where would they store it? Where would this fluoride varnish be stored if they were conducting a caries risk assessment on these children? So outlining all these different things throughout the focus group sessions, I just went about it and divided it up based on profession and tried to highlight what main things each profession was trying to talk about. So some key quotes that I was able to identify was a nurse practitioner, in terms of the time aspect or the theme, was that early childhood caries is a very overlooked issue in primary care, especially in at-risk communities. It's a well-known thing that it's very prevalent, has been unchanged in the past 3 decades. So although that we know children are affected by carious lesions, it's still something that's very overlooked in primary care and not dealt with. A physician assistant did mention that they don't know how to do fluoride varnish or what it entails, and it would potentially require more time. So again, it goes back to the limited time slots that each primary care provider has, and that was being cited as a significant barrier. Now, in terms of value, one nurse practitioner did mention that a tooth and malocclusion, you can say something, but it isn't high on our priority list. When it comes to ear infections, chest infections, then we are not really thinking of that. Now, that can be for all primary care providers too. It's that you're trying to deal with the chief complaint in the limited time that you already have. You're trying to do your whole history and physical. So do you really have the time and value to conduct a caries risk assessment tool? That was one of the significant things identified by this participant. But on the other hand, one physician assistant did say they would make the time to fill out this tool because there's always opportunity to provide better care and improve for the patient, and this is essential. So there are providers here that feel that if we can provide the service, it can actually be really beneficial for these children that come in with these carious lesions. Now, in terms of training, as I mentioned before, we don't have in the medical profession, in our training or in the nursing profession, something that clinically outlines oral health care and how to conduct oral health screening. So that's something that was identified by a physician assistant, and how we can see whether physicians and PAs can actually approach this rather than just sending the child to the dentist. In terms of comfortability, one big quote that I had was, from a bang for a buck perspective, it's not something I've been trained to do, so it's not easily implemented into practice. So again, it's something that needs to be repetitive and something that needs to be valued from both the provider and from the patients, as well as getting comfortable with conducting this. In terms of information to educate others, I noticed that the referral process was identified as a key barrier. So one physician did say they don't know the community dentist. They don't know who's good with children, who has forgiveness for no-shows, which dentists are close by. So they would struggle to send people to the dentist. So again, it's that disconnect between the medical and dental profession that was identified as a key barrier to information to educate others. In terms of funding, one nurse practitioner noted that, you know how funders are, they want to see economic value of it. So if you're working in a setting where it's a provincial primary care clinic, such as in Winnipeg, it's a Winnipeg Regional Health Authority funded clinic, you would have to show what the economic value of providing a caries risk assessment tool in these practices is, so that you would get the funding to get the tools, to get the fluoride varnish to actually conduct a caries risk assessment tool. So that was one of the key barriers identified. And again, in terms of storage, where would it be stored? How can it be applied? Do they have to keep the kit around to have it set and dry? Was one thing identified by a physician assistant. So again, the education aspect to the provider, as well as figuring out how we can go about storing these tools that are needed for a caries risk assessment tool. And in terms of education, some providers did mention, such as a nurse practitioner, it's just become an accepted culture in high-risk communities that people will just have extensive childhood tooth decay, and it's going to be a natural process for the family and children in the family. So some providers do think that even though we can provide this service, not everyone will be receptive to it. And it builds on to the value is that we would have to get parents to buy in and to appreciate what a caries risk assessment is, what the benefits are, and how the long-term prognosis can be improved for these children if we can utilize this in primary care settings. So in terms of my discussion, once I had all these results, I went about into the literature and see what the other researchers have identified in similar research projects. So one thing I found was that 46% of Canadian pediatricians and 62% of Canadian family physicians actually lack the knowledge in recognizing the early signs of tooth caries. This builds on everything that I've mentioned, where it's hard for primary care providers to actually know and identify based on sometimes the pictures or just Google images, but what an early childhood caries looks like and how to recognize it to intervene. So it's builds on the fact that the medical and the nursing curriculum doesn't really address this, and that's more so focused on the dental side of things. And one study that I found that was conducted in Saudi Arabia, it showed that pediatricians and family physicians who were conducted under, who had some research done about the caries risk assessment tool in their country, showed that a lack of clinical time was reported as their highest barrier. So again, that was something similar to my project, where I had multiple participants say that the lack of clinical time in their appointment slots may be a big barrier to implementing this caries risk assessment tool. And the same study actually also noted that an enhanced referral system between the medical and dental community is needed. Again, it's easy for the primary care providers to refer to the endocrinologist, but it's very hard for them to figure out who the community dentist is. And that is something that was identified in this project. And it was mentioned by a couple participants too. So just having a bridge and something to bridge the gap between the two professions would help actually utilize this caries risk assessment tool to its full ability. So in the end, what a benefit of a successful CRA tool would look like? Well, I was able to look at a study in the US that showed physicians who were able to provide preventative oral health services, such as screening or referrals or fluoride varnish, ended up having decreased caries-related treatment in Medicaid enrolled children. So there is clearly a benefit for primary care providers to actually provide oral health services and lead to decreased incidence of carious lesions. So from a Canadian perspective, I had one study that showed that the use of fluoride varnish in primary care settings in Ontario demonstrated that participants had a lack of training methods, especially in physicians and nurses that they entailed in their project. And they also identified that there was insufficient time during their well child visits to conduct the use of fluoride varnish, again, mentioning the time aspect. Funding issues, where would they have funding to get fluoride varnish, who would pay for it, and is there an actual value? And then again, the difficulty in applying fluoride varnish. So the training aspect, how do we train these primary care, non-dental primary care providers to provide this service to children? So there is some broader overlap between what I was able to find and what there is in the literature. So the broader and all-encompassing point that I had was that the themes identified in my project do also have similarities to results in the literature, whether that be the appointment time slots, the lack of training methods, the storage, and the funding issues per se. So in terms of limitations in my project, initially I went about trying to have a goal of 15 participants, but I ended up with 8. Now, given that the COVID-19 pandemic was evolving and going on, I did have trouble with some participants who initially were interested, and then they were either redeployed, had a change in their scheduling that I just couldn't match my times to conduct a focus group or interview session. So that led to a smaller sample size. But I was happy with the 8 that I did because I had a wide variety of roles, whether that be PAs, physicians, and nurse practitioners, and a large, wide variety of interaction with pediatric and Indigenous populations. Also, the majority of my focus groups were conducted on Zoom. So only one of my research focus group sessions were done in person. So I felt that I was able to elicit more participation and interaction between participants when the focus group sessions were done in person. So I think for future projects, this would be something to consider, whether we can conduct more in-person focus group sessions. I felt that in participants over Zoom had more distractions, whether they would be at home and have children around or whether they have pets. It would be more interactive if they were in their clinical settings and having these focus group sessions in person so that they can bounce ideas off each other participants and have more of a discussion as to what the barriers would be and able to answer the questions in more detail. Another limitation that I had was the focus group sizes. So I did have 4 focus group sessions, but 2 of them had 2 participants, 1 had 3, and 1 was just done as a one-to-one interview. So I felt that I could have a better focus group size standardized, meaning that if each focus group session was done with either 2 participants or 3 participants, I could have a standardized approach to see how much interaction is occurring between participants. Are they bouncing ideas off each other, expanding on each other? So I felt that standardizing a focus group size would be better going forward in future research projects. And finally, the last limitation I had was that the regional data. So everything that I did was from Manitobans, non-dental primary care providers, and it's not really representative of barriers to implementation in other parts of Canada, such as in Eastern Canada. They have different population groups, they have different issues in their communities. So although early childhood caries is prevalent there as well, primary care providers there may have different opinions about the implementation and barriers in their clinical settings compared to somewhere in Western Canada. So I felt that having a broader perspective and looking at more non-dental primary care providers in different regions would be better for future projects. And finally, for future direction, I wasn't able to get primary care nurses, as mentioned earlier, but also dietitians and social workers was something that I didn't have in my project as participants. So I would look to include those to get broader perspective from their roles. Non-dental primary care providers encompasses a wide variety of roles, and having each and every provider from their perspective provide their opinions as to what they would see as an implementation barrier would help gather more data and give us a broader perspective to actually learn to implement this Caries risk assessment tool in practice. And the other thing was to increase the sample size. Obviously, I only had 8 participants, so conducting a larger sample size with a study on a national level would actually help to analyze regional barriers, whether that be between Western Canada, Eastern Canada, Central, Ontario versus Quebec. That would help analyze regional barriers, and then the urban-rural divide, whether we can have studies comparing urban centers such as Winnipeg to smaller centers such as in Thompson in Manitoba. That would actually help identify different barriers to implementation in urban and rural settings. So to conclude, I was able to gather data and identify 4 themes as potential barriers to implementation of this Caries risk assessment tool, one being time, provider education, access to resources, and parental buy-in. It was limited by a small sample size and the fact that I conducted this mainly with participants in Winnipeg, but also practicing in other parts of Manitoba. So looking at the whole project, I believe that for future research, it's important to expand on this by getting a larger sample size, again, looking at it on a national study and encompassing things that I was able to identify, such as having time and provider education, maybe expanding that in focus group sessions to facilitate more discussion, and also trying to standardize the focus group sessions and hopefully having more focus group sessions in person to facilitate more discussion and get more honest opinions from all the participants. And that's the end. I just wanted to give a small acknowledgement to my capstone mentor, Dr. Robert Trott, and the entire Healthy Smile, Happy Child team for their help and motivation, and to all participants who participated with the completion of my thesis capstone project. And these were just all my references that I used in the project.